So like I said, my name's Dana Ritchie. I'm with the Greater Cincinnati chapter of the Alzheimer's Association. I'm the education and community engagement manager. I have too long of a title. I think we need to do something about that. And so we are thrilled today. This is the beginning of our March expert series, and we picked a great way to kick it off with Lynda Anello. She is the community and admissions liaison for VITAS Hospice, but she is also certified first steps advanced care planning facilitator. And so that's a lot of what we're going to talk about tonight is advanced care planning for a loved one who has any type of dementia. So I'm going to turn it over to Lynda. And Lynda, if you want to share anything more about yourself. And then again, if you guys have questions, you can use the chat or raise your hand in Zoom here, and we'll make sure we get your questions.
Hi, everybody. Welcome. Thank you for joining us tonight. A bit more about me. I have worked in hospice for 13 years. So I know a little bit about hospice, but I am not a clinical person. I'm not a nurse. So even though I know about hospice in general, I am not clinical. So I want you to know that. Now, of course, we have plenty of expert clinical staff. And so if you have tough questions that I cannot answer because they're too clinical, I can get you the answers through our staff. My role is a liaison. So some of the things that I do is I do education presentations like this. I also meet one-on-one with patients and families and help them have conversations. We call those goals of care conversations. So it's an advanced care planning type of conversation. My passion is to have people be proactive and plan proactively so that they can be empowered to have their voices heard and their decisions and their values noted while they're able to speak on their behalf. So anytime someone has a disease like dementia that's going to rob them of the ability to be involved in care planning decisions later on down the road, I like to try to encourage people to do that in the early stages while they can be a part of the conversation. And then I also help families of loved ones who can't participate in the conversation to talk to each other and process their thoughts and feelings and what they're going through and what they wish for their loved ones as dementia continues to advance and they're facing end-of-life decisions. So that's what I do. And some of the values that hospice espouses, we really believe in self-determination. So that's where we like to get people, while they're able to speak on their behalf, to tell us what they determine, what are their goals, what are their values and their wishes. We like people to have a voice as long as we can accomplish that early on. We think it's really important for people to make decisions based on good information. And we value the decision-making to be shared between providers of care and the patients and families that will be affected by that care. So it's very inclusive of everybody's opinions and thoughts. So it's very person-centered, very family-centered. We're not caring just for a patient, we're caring for a person and their family who are going through some hard times, and we're just there to try to make it better in a very holistic way. So not just looking at a disease or, in medicine, often we are very compartmentalized. We look at a heart, if you're a heart doctor, you look at lungs, we look at different parts. But in hospice, we're holistic. We're looking at the whole person, psychological, emotional, social, spiritual, in addition to physical. And ultimately, when it comes to the end of life, our philosophy is to make that, it's a natural process. We all die, and we want that to go naturally, peacefully, pain and symptoms managed so that it can be comfortable and dignified. So we are less is more, not the aggressive, do everything until the bitter end kind of approach. Where the let's have people, not suffer. That's the goal. Okay. So tonight we're going to talk about advanced care planning, and I think I can share my screen, right?
Yep, you should be able to. Do you see a share screen button at the bottom?
All right. Hold on just a moment. I'm going to get the presentation up first. Let's click on share screen. There it is. It's not letting me. Sorry, hold on just a second. I'm having an issue with opening it. Why won't it let me open it? Okay, now maybe it'll let me open it. Sorry, guys. Okay. Now that I have that open, trying to close everything else so that when I share my screen, it's on the presentation. Okay. Share screen.
Zoom should let you choose what you want to show and what you don't want to show.
We can see it now.
That looks good.
Yeah.
Okay. Sorry it took me a minute. All right. So this presentation is called Proactive Care Planning for the Advanced Stages of Dementia. And the goal of the presentation is to encourage proactive planning for the advanced stages of dementia in order to maximize the quality of life for individuals and their families. Let's see if I can move this thing. Okay, good. Our objectives. So we're going to go over advanced care planning. We're going to talk about the importance of having a goals of care conversation. We'll explain what services hospice provides and how to identify a patient who is eligible for hospice. All right, so we're going to start right away with advanced directives. Some examples of advanced directives would be the living will, the healthcare power of attorney, and also organ donation. Now, you don't have to do all of those things, but in the Ohio Choices booklet, those things are all included. So the living will is the form that indicates what you would like to have happen if you have, if you're permanently unconscious in terms of life-sustaining treatment, such as life support type treatment. Healthcare power of attorney, that's the person that you're going to designate as the person who will speak up on your behalf for your healthcare decisions if you're not able to speak up for yourself. So as long as you're able to speak up for yourself, you're making those calls. But if anything should happen where you're unable to, whether that's temporarily or permanently, then you have a healthcare power of attorney as your person to speak for you and make those decisions for you. And then, of course, organ donation is an optional form in that booklet as well. So if anyone on this call does not have advanced directives and needs more information, I am able to email those documents to you and go over them with you as well. Let's see, I'm looking to see, I think I already said that. So in 1990, Congress passed the Patient Self-Determination Act. All healthcare providers who receive Medicare and Medicaid funds must provide information regarding advanced directives to patients admitted to their programs. So that's probably something that you've heard often when you get any kind of procedure done medically is someone to ask you, do you have an advanced directive? We recommend any adult 18 and up should have an advanced directive regardless of your health status, because things happen, as we know, unexpectedly. So it's always important to have these things in place. The cases, the litigation that led up to this law being passed were all cases of young women who had unexpected and sudden events that led them to be on life support, where their families had to then fight to have the option to remove them from life support. So that's why these things were created, because you never know what curves life is going to throw you. So better to have these things planned in advance, and then you don't have the struggles that those families had to go through. Do not resuscitate orders are something that we plan for, or we talk about when we're doing advanced care planning, especially when a patient has advanced illness. It's really important to understand a lot of interventions were created for younger, healthier people. And CPR is one of those inventions that came about. It was never intended for people who were quite a bit older and had a lot of health conditions. In terms of, based on your health status, one intervention can be appropriate and helpful, or it can be, it can cause pain and suffering and burdens and do more harm than good. And so one of the things that I go over when I talk with people about goals of care is to really help them understand what it means to have CPR and life-sustaining measures taken based on their health status, what the pros and cons might be, what the chances of that being successful for them might be, and then whether or not they want to implement a do not resuscitate order based on the good information, not just across the board. So resuscitation is attempts to restart the heart and breathing. So if you don't resuscitate, then that is a natural death. The heart has stopped, breathing has stopped, that is a natural death. Resuscitation is trying to reverse that process. Also, machines, technology can be used. And then this is, okay, so I've already gone over that. Once advanced directives are signed, they don't have to be, you don't have to go to a lawyer to have that done. These forms are readily available and free online, and they just need to be signed in front of 2 witnesses, or they can be notarized. They don't go into effect unless you're unable to make your own decisions. So as long as you're able to make your own decisions, that's just a backup plan for the case of when you might not be able to make your decisions in the future. So just having an advanced directive doesn't mean you're giving away the power to make your own decisions. It's just having a backup in case you need it. And again, you don't need a lawyer. You don't need to spend a lot of money. This can be free and easy to accomplish with 2 witnesses or a notary. Notaries are often free at libraries and banks, for example. And for VITAS patients, I'm a notary. Okay, so getting the paperwork done is one thing, but just the paperwork, just the advanced care planning paperwork is really insufficient. What's more important, or as important, is to have a really in-depth goals of care conversation, especially as people are aging and their care is becoming more complex. And by the way, Dana, I can't see anything other than my presentation. So if
Yes.
you're going to have, I don't have any visual ability to see you. So just interrupt me if you have questions, okay?
Yep, that's why I'm on here to moderate it for you. No problem.
So as people age and they start to have more and more chronic illnesses, the picture of their care becomes more complex. And a goals of care conversation, therefore, should not be a one-time conversation. It's an evolving conversation. And it should become more and more specific to what's going on with your particular healthcare complications as those develop. And the reason that this is important is because, there are people who have wishes of how their end of life experience will go. For example, they may wish to die at home. it may be very important to them not to end up on life support. So a lot of wishes that people have are not actually realized, because without really careful planning and conversation in advance, what ends up happening is a crisis that gets out of control, and things take a turn and you don't have a chance to stop them once they are in motion. So that's where advanced care planning conversations are so important. Patients often think that their clinicians, their doctors, will initiate the discussion, and they kind of often might think, well, if it hasn't been brought up, it must not be something that needs to happen. Well, the truth is that's really not happening adequately. Many doctors are not comfortable, or they may not have the time. So really good advanced care planning conversations. It's important, I think, with all healthcare, that we take our healthcare into our own hands and have empower ourselves and our loved ones to really initiate conversations and ask questions and advocate for ourselves, rather than waiting for somebody else to bring it up, because it may not get brought up. And like I said, there are, not everybody's comfortable having these kinds of conversations. That's why I do this. I do this for people, help them have these conversations, because I am comfortable having them. And so just, if you need help, you can reach out to me for that. So in the beginning, you want to find out, does the patient have a completed advance directive? Have they assigned a healthcare power of attorney, a surrogate decision maker? If not, the next question would be, do they have the decisional capacity to be able to do that? Again, that's where I was speaking earlier about the importance of trying to get these things done while we're well. So to evaluate decisional capacity, that's going to be done by a medical person. But here are the guidelines that they will look for. Is the patient able to receive information and communicate effectively about treatment options? Do they understand the options? Can they evaluate them, deliberate on them, and mentally manipulate that information? Can they use logical reasoning to make a decision? Can they evaluate risks and benefits of those decisions? And the goal is that they're making decisions that are consistent with their lifetime values as a person. Can they communicate their preferences? Are they able to make free and voluntary decisions without any coercion, manipulation, confusion? And do they understand the outcomes of the choices that they make, especially if they're making a decision that may have an adverse effect? So that last one, as an example, when we talked a little bit ago about the DNR, the CPR decision, many times people are making decisions like that and don't really understand the outcome of that choice. I think that in healthcare in general, we don't do a good job of helping people understand the adverse effects of some decisions. Another example would be dialysis. Many times, dialysis is initiated very late in life with people who have multiple comorbidities, and the outcomes of that decision are very burdensome, very negatively affecting quality of life. I've spoken with many patients who are on dialysis who say to me that they regret it, but they really didn't understand the decision when they were making it. Or they may have even said, I don't really feel like I made a decision. I was just kind of told this is the next step and this is what we're doing. So really important as people age, and especially as they have multiple chronic health conditions, that every decision for an intervention is really looked at according to burdens and benefits of treatment. So when we start the conversation, we want to have an appropriate setting and make sure that the right people are there. So who are the right people? Well, it depends on who's calling the conversation, who's asking for the conversation. If the patient is able to and has agency and ability to say who they want to have present, that's where we start. But it's really important that any stakeholders are present, because sometimes complications happen if, let's say the patient has a power of attorney that's a daughter or a son, and they don't invite the other siblings to the conversation or communicate the decisions that were made in the conversation afterwards to those siblings. Then when the time comes to, when the patient has lost capacity and that POA steps in to make decisions, they may get a lot of pushback because they weren't part of that. They didn't hear the patient express their wishes. So it's really important that everybody who may have a stake in that outcome at least be informed of the conversation and the outcomes of the conversation.
Hi, Linda. We have a question here in the chat. If someone doesn't have decisional capacity, then
Yes.
is it up to someone else, like a spouse or next of kin,
Yes.
to make the decisions?
That should be a slide.
Okay.
I hope it's in here. There should be a slide coming that shows how that capacity, the order of who's determined to be
Okay.
in line. Yeah.
Okay.
So hopefully that's in here. If we don't get it, definitely ask me again and I'll make sure and get you the information. But when we start the goals of care conversation, we want to have a comfortable environment. When I have goals of care conversations, I meet people in their homes because that's where they're comfortable. And we start really slowly. With a calm atmosphere, build rapport with people, make sure that they feel, I think it's more effective than like in a clinical setting where you feel a power dynamic sometimes in a clinical setting where the doctor feels like an intimidating presence. When I do a goals of care conversation, it's just me, person to person, and then we talk about why are we raising the topic now. So the reason I'm going over with you is a lot of families have a hard time saying, we know that we need to have this conversation, but we don't know how to bring it up. It feels awkward or it feels scary. So this is how we set this up. And like I said, I do this and I help people do this. So why are we bringing the topic up now? And there could be some things that have happened recently that are leading us to bring this up now, or it could be we just want to talk about it proactively and get some things planned. We don't want to wait until we're in the middle of a crisis. We want to hear your voice now while we can hear your voice. So again, if the patient is able to participate. And then we start with going over what's been happening, what's the current medical situation. So with that, I have the patient and or the family just kind of tell me their story. What's been going on over the past year, or maybe it's been over a period of time. How has that changed over time? What do they think about the future? What kind of concerns do they have about decisions that might be coming up? Things like that. And one of the goals, again, I said I'm not clinical, so I do my best I've gained a lot of knowledge over my years in hospice. I do my best to help them think through the course of illness and potential decisions that they may be facing. But then I also encourage them to clarify with their doctors, what is their prognosis? And sometimes what I help them do is make a list of really good questions so that when they do see their doctors, they know not to forget, to go over with their doctors. Here are my concerns about the future. Here are my confusions about my current prognosis. And I'm trying to make a decision about CPR. Can you help me look at the pros and cons, that kind of thing. So part of the goals of care conversation is helping them come up with a more effective way to communicate with their own doctor as well. And then, we're looking for their underlying values and goals. Part of this is to look back at their experiences in life and what shapes them. So some of that is looking at how loved ones or people close to them, how they passed away and what went well and what didn't go well, and what they learned about themselves by watching that. I would have wanted this or that. When I see how my mom passed, this is what I thought well, or this is what I thought did not go well, and what I would want based on that. And we look at, what are probabilities. So for example, when we're talking about dementia, we know that eventually one of the complications of dementia is that people have a difficult time with swallowing, and they may be facing down the road a decision about a feeding tube. So that's a medical probability that we can talk about early instead of waiting until we're in the middle of a crisis to try to figure out what we want to do. When we talk about it early, then we can look into research. If you're a person who wants to look things up and find out what are the complications of this type of intervention that I might need to consider, that kind of thing. It gives you time to ask good questions, do your research, really think about what you would want, rather than waiting until you're in the middle of having to make that decision on the spot. So we're just all throughout the conversation clarifying and confirming, validating their goals, their wishes, their values, helping them process kind of, what's important to them, and grounding it in their experience, current experience, as well as previous experience. Take it very slow. So a goals of care conversation at minimum usually lasts an hour. I have had goals of care conversations. The longest one I think was 4 hours, and that was a large family with a lot of siblings and a lot of different opinions that needed to be processed. So it involves a lot of listening and validating and trying to get to what's underneath. What are the emotions and concerns that are underneath? And that's usually, or that's really what makes these decisions hard, is there's a lot of buried complexitions, emotions about relationships, unprocessed, kind of relationship strife can be a part of this, or guilt that people have, identity concerns, especially with caregivers who've been caregiving for decades and have really identified with the role of caregiver, and the idea of, just the idea of loss. I mean, these are really tough conversations. So it's important to give them the honor of time and good listening, and really, exploring them deeply. In the goals of care conversation, it's really important to ask tough questions, but timing those questions is important as well. So you don't want to put people on the spot with questions that are hard for them when they're not ready, but you want to gently help them get to the point where they're ready for some tough questions. And this is something, like I said, that I've been doing now for years with VITAS. So I've developed the ability to figure that out over time. And that's where I'm able to help people have these conversations where, I have a lot of experience with it, where it will be harder for them because they don't have that experience. Okay. You know what? I'm hoping that slide about decisional capacity didn't get left out. I feel like it should have happened already. So if we don't get to it, I will send it to you separately to make sure everybody gets it. Because now we're going into talk about what is hospice. Now, before we move to that section, what is hospice? The first section I kind of breezed through, I think, kind of quickly. Advanced care planning and goals of care conversations. Do we have any questions from anybody before I move into explaining hospice? Anybody?
Question. I just have a Lynda, can you hear me?
Yes. Hi, Stephanie.
Okay. All right. Having just a couple thoughts on the do not resuscitate order, and this is related to experiences with both of my parents, is that the DNR may vary by state. Both of my parents were in Michigan, and if you cannot provide the DNR paperwork by law, at least in Michigan, they have to try to resuscitate.
Mm-hmm.
And the other thing is, the importance of the placement of the DNR. So
Mhm.
people know exactly where that paperwork is if there is an emergency, and if they are in a healthcare facility of any kind, to make sure that they've got a copy of the DNR on file.
Stephanie, those are really great points. I have personally had experience with that in the last year, where my mother was hospitalized repeatedly, and I took the DNR and I said, please put this in your files, but it seemed like it wasn't, when they needed it, they couldn't find it. And I was on the phone with them for, over a half an hour, insisting that they find it before anything was to go wrong. So
Right.
it's an excellent point. As a matter of fact, I keep my mother's DNR in my car now, so that if I ever have to take her to the hospital again, I have it with me. I've taken a picture of it. It's on my phone. You're very accurate, Stephanie. There's a couple of challenges with advanced planning. One of the challenges is that people are not doing it, and not enough people are getting that planning done. So getting the forms completed is one problem. Having the conversation is another problem, because you can't just do the forms and not have the conversation. Because when it comes to the tough decisions, your family needs to have heard you more than just having the forms. The forms are too simple. They don't cover all the bases of the decisions. Speaking of that, I have a specific directive for dementia that I can share with people as well. But the advanced care planning documents are very simple. They're the living will and the power of attorney. They don't cover a lot of decisions. They don't talk about feeding tubes. They don't talk about dialysis. There's so many decisions that families have to make. So really understanding how a patient makes those decisions, what value system are they using? What are their goals? Because if you understand more broadly what's important to them, then it makes each individual decision a lot easier, because you can put it in the context of, I know their values, I know their goals, right? And a lot of people, to your point, Stephanie, especially if they are very advanced in illness and have a lot of exacerbations of illness, that they're on that kind of roller coaster ride of ups and downs, they will keep their do not resuscitate order on their refrigerator somewhere really easy. I've seen people keep it on their front door even. And to that point as well, why call the squad if you don't want resuscitated? Because if you're going to call the squad, that's their job, is to resuscitate. So that's another thing that I try to encourage people. Do you mind the light? Yeah, thank you. I do try to encourage people to think about, do you really want to call the squad? And that's one of the benefits of having hospice involved, because if something starts to go wrong, you have someone to call other than, the squad, because, there's a different approach. If you call the squad, or if you go to a hospital, there's a more aggressive approach to care. But if you have hospice as a team involved, you have someone to call who understands that you want pain and symptom management and comfort, but you don't want anything aggressive. That's one of the main benefits of having hospice involved, is having someone to call when those things start to happen.
To that point also, I think it's important for people to realize that even though you're involved with hospice, it doesn't mean that you might be end stage. It's an introduction to the organization, so that when you do get to that point, you've got a resource. And I really had told my brothers I really thought Mom would benefit from hospice, and she was never end stage. She just liked to live in the crisis mode. We have to laugh about some of these things. But I think there's such a value just to let people know that, you can get a second opinion about this, or a second opinion about this, or what kind of support can hospice provide.
Right. We're going to try to get to that next. Very good points. And I appreciate you, Stephanie. Hospice has gotten a stigma. And a lot of, when I ask people, when I say hospice, what do you hear? What do you think? What do you imagine? Thank you. And it's, people think often that hospice means I'm going to be dying in the next week or two, a few days, whatever. And the reason people have that thought about hospice is because so many people wait so late to call that by the time they call, that happens, death is near. And then it reinforces the idea that somehow calling hospice led to an end of life event happening. But if you wouldn't have called hospice, it would have happened anyway, so it's, a lot of my education is trying to help people see hospice differently and call much earlier. And like in the case of my mother, I called and had her evaluated for hospice 3 times before she finally made eligibility. I wasn't waiting until I was sure she was going to make eligibility. I wanted to get her on as soon as she could make eligibility, because I know that the sooner you take advantage of those services, the better support you have and the better things go. I know that because I work in hospice. If more people understood hospice, they would be calling much earlier. So I appreciate that, Stephanie. Thank you for your input. Is it okay to move to the hospice section?
I just have a quick question.
Sure.
The healthcare POA and the living will are the
Yes.
only directives.
So in the, there's a booklet that in Ohio called Choices. And in the Choices booklet, you have the living will, you have the healthcare power of attorney, and you have an organ donor form. Those are your options in that booklet. That's just that booklet. There are other things you can do to be proactive. As a notary for hospice, I'm often called in to notarize for people who are, very close to the end of life and don't have those things in place. One of the other things that I'm often asked to notarize is a financial power of attorney as well.
Is
So-
that the durable power of attorney?
Yeah, durable meaning that, so you can have a durable power of attorney for healthcare and for finances, but it's durable meaning that even when you're not conscious, when you're not alert, that still stands, that person still has that authority to make those decisions for you.
Okay, is there some kind of expiration on any of these, or are they good forever?
Well, once the person, so for the financial power of attorney, once the person passes, then the financial power of attorney, if I understand this correctly, now I'm not an expert on this, on the financial piece, because I'm in healthcare, but I don't believe that continues after the person passes.
That is correct, Lynda.
Okay, thank you.
Yes.
But yes, so, and of course, once the person passes, then there's no need for healthcare decisions to be made. So, but other than that, I mean, like if you had done your power of attorney forms very early, like I have some people who did them 10, 20 years ago. So it's always important to look at how long ago was that? What has changed since then? For me, when I did mine, I was 23. Recently, I looked at them and the witnesses that signed them were no longer alive. And one of the other changes is now I have adult children to consider. So it's, and the other thing that could change is as your health conditions change, or as your experiences with healthcare change, your opinions and your values may change as well. So it's always good to, it's not a one and done, like do it and stick it away somewhere and forget about it. It's really good to have continuing conversation and to always make sure that these things are documented so that, your family knows exactly what you want if they need to make decisions for you. These are great questions. Thank you. I appreciate you guys, because I did breeze through that because really when I put this presentation together, I have a presentation specifically on advanced care planning that's much longer. And I have one on hospice, and then I have another one on goals of care. And so I really wanted to give you a taste of all of them. And since I didn't know how, I took from so many different presentations, I was afraid to take too long on the slides and run out of time. So I appreciate you guys helping me with the questions to go more in depth. Thank you. Anybody else? Okay, so we're gonna go into what is hospice next, okay? I'm gonna minimize so I don't see you guys so that I can see my slide. All right, so the value of hospice. So hospice is pain and symptom management. We don't do anything curative. We're not trying to fix a disease or stop someone from dying if they are dying. Our goal is optimizing quality of life through pain and symptom management. We also don't just treat physical pain and symptoms, but we also look at what is going on with them emotionally, psychosocially, spiritually, because as your life is coming to a close and as you're experiencing more and more illness, that affects you in more ways than physical. I mentioned earlier the spiritual aspects. Sometimes people have guilt or unresolved drama or conflict in their lives with certain people, and they really need help processing their past experiences, making amends sometimes, finding forgiveness. There's a lot of complex tasks that happen at the end of life that we can help people with, not just pain and symptoms of a physical nature. But hospice also provides medications, medical supplies, and equipment. And Medicare covers hospice at 100%, Medicare and Medicaid. So not only are we providing a care team, medication, supplies, and equipment, 24/7, 365 days a year support, but it is almost completely paid for by Medicare and Medicaid. I mean, and many private insurances as well. So the cost is negligible to nothing. And we also really are not just caring for the patient, but we're caring for the family, helping them, instructing them on how to care for the patient, and supporting them emotionally and spiritually as well. We have short-term inpatient care available if pain or symptoms become difficult to treat at home, or if the caregiver needs a respite for a short period of time. And we provide ongoing care even after the patient has passed, bereavement care and counseling. And even actually before the patient passes, there's a lot of loss that happens with chronic illness as death approaches. You're adjusting to a lot of loss. So we're helping with that kind of bereavement counseling throughout and after as well. So there are 4 levels of care in hospice. The routine home care level is wherever the patient calls home, whether that's their own individual home or if they live in a community like long-term care community. But routine home care, they have a caregiver who's providing their day-to-day care, and we're coming in as a support, as an extra layer of care. So even if they're in a nursing facility and they have nurses and aides in the facility, we are an extra team of care coming in to care for that patient. Routine home care, they develop an individualized plan of care to determine how many visits per week from the nurse, from the aide, from the chaplain, from the social worker, etc. Then if a crisis comes along, a pain or symptom crisis, we have a couple of higher levels of care. One is called intensive comfort care, or it's also called continuous care. So that is still in the home setting. The difference is we're not just making a 1-hour visit here and there, but for this type of care, we're going to spend a minimum of 8 hours at a time with that patient. And up to 24 hours or consecutive days while that crisis is happening until we can get that patient stabilized and back to the routine level of care. The highest level of care is inpatient care. And for VITAS Healthcare in Cincinnati, we have the 5th floor of the Drake Post-Acute Care Center is our inpatient care unit. Other options could be, if you don't live near there, a contract bed somewhere. We could contract a bed a hospital or a nursing facility as well. But inpatient level of care is the highest, and then respite care is for a period of about 5 days. Here, we have more than one of these, but a respite for the caregiver if they need to have a surgery or if they need to leave out of town for a few days or something like that, if they need a respite from caregiving. So the yes.
We have another question. Is the intensive care limited to just a certain number of hours?
In the continuous care in the home,
I think it said intensive care on your slide. Intensive comfort care.
the second,
Yeah,
it's called
that second.
intensive comfort care or continuous care in the home.
Mm-hmm.
It's a minimum of 8 hours and up to, it could be, I say 24 hours, but it really could be more than that because it could be days. So it depends on what's going on. It depends on, the goal of the care is there's a crisis, there's a pain or a symptom crisis. We're there to keep close watch and make adjustments and get that patient back to stable enough to have routine home care. So we're there as long as we're needed for that level of care. And it could be, it could be part of the time nursing care, and part of the time it might be an aide just to keep watch to make sure that the patient's okay. But does that answer the question?
Yeah, I think so.
Okay. So the types of services we provide. So there would be a nurse, first of all, who would be doing all of the assessment of pain and symptoms, any medication changes. She's working closely with the doctor. The doctor in this case, we have our own hospice trained physicians, but then some patients also have a specific doctor that they're close to, that they trust, and they would like that doctor to stay involved in their care. So that there can be a combination of the VITAS physician and an attending physician that the patient has determined that they would like to stay involved. And then the aide comes for any personal care needs, bathing, dressing, feeding, toileting, things like that. The social worker is there to help with finding resources in the community, doing some pre-planning, like if the family wants help with funeral planning, or they, the social worker and chaplain both can provide emotional support and a listening ear, that kind of thing. And so grief and loss counseling could be done by the social worker and or by the chaplains that we have in service as well. And then in addition to the care team, also on the care team, we have volunteer services who do a lot of great things, like we have a Paw Pals program that does pet therapy. We have a music therapist. So we have many different roles of people that are helping the patient and family. But in addition to the people involved, we also provide medical equipment. So if the time comes that we need a special kind of bed or a special kind of mattress to prevent pressure ulcers, a walker, for example, a bedside table, a special chair that helps lift the patient up out of the chair. Lots of different types of equipment needs, oxygen, things like that, and supplies like incontinence supplies, for example, and drugs that are related to the terminal illness that are used for symptom and pain, control of pain and symptoms. So these things are all provided. Now, before I go on, I'm going to just check. Are there other questions yet?
We did have one question related more to back to the end of life decisions that you would put in a living will. So you'd mentioned CPR, but is there some kind of comprehensive list?
Right. So the unfortunate thing about the choices document that I was saying earlier, the living will is basically the living will says, if you if two physicians have determined that you are permanently unconscious and that any interventions of a, a technological nature, like supplying nutrition or hydration technologically, if those interventions are not going to provide any benefit, then, at that point, would you want to be on life support, either have it started or have it removed? And if your answer to that is no, then that's what the living will does. It gives permission for your care team or for your power of attorney either to not put you on life support, or if you're already on life support, to remove you from life support. That's what the living will says. It's very limited. And that's where I was saying earlier, I have a dementia specific directive that a physician in Oregon created. I think he's in Oregon. His name is Barack Gaster. He created a dementia specific directive that's a little bit more nuanced and has more decisions in it. But that's where the goals of care conversation I find is really helpful, because I try to go more in depth with the patient and family to think about, let's talk about other decisions that may be coming. So oftentimes if a patient is facing or could be, it's looking like their kidneys are starting to get to that point and they're going to be facing a decision about dialysis, oftentimes I'll get a referral to have a goals of care conversation with the patient and or family to talk about the pros and cons of dialysis and what kind of questions they may want to ask their doctor before they make that decision. But I don't find that there are really great tools like that. I think that that's a missing. It's not like one tool that has all of those boxes checked, And so I try to do that individually when I have goals of care conversations. And as I have more and see more, I learn more about what kind of things I need to include. And they're really specific sometimes to the disease process that you're in. Like certain diseases, you're gonna have more the feeding tube kind of decision as a matter of course if it continues along its normal course. So the answer to that is it's really, it behooves you as a patient and family to do some research or ask good questions about what are the potential decisions that are coming down the road for this particular disease. What am I going to be facing so that I can find out now what I need to know for down the road. I think that our healthcare system could do a much better job preparing people for those things, and we just don't. I haven't found that to be the case. I found it to be quite poor, actually, because our healthcare system is focused on treatment. It's not focused on planning for end of life. Our doctors are not well trained for having end of life conversations. It's very reactive. It's not very proactive often, that's what I see. I see that it's like, well, we'll try this, and if this doesn't work, then we'll do the next thing, and then we'll just keep offering you something else and something else and something else without ever stepping back and looking at the big picture and saying, is this helping or hurting? Is this what you want? So that's what I try to do with the goals of care conversation.
Lynda, I have a question. You just mentioned, a phrasing that you said, a list of the things that are specific with Alzheimer's. So I'm an adult child. My father is the caregiver to my stepmother, who is in mid-stage to late stage Alzheimer's. We're 8 years in, they never had the conversations. My dad is also having difficulty having the conversations.
Yeah.
So I'm actually in Florida currently here to have conversations. That's why I flew down here from Ohio for Cincinnati. Is there somewhere to find a list of these Alzheimer's specific things, of potential things that he will be looking at, because now she obviously is no longer able to make these decisions for herself, that as caregiver, as the spouse, as the one who would be the one making these decisions for someone to glance at those maybe as a, uh-oh, yeah, I guess I need to
Right.
think about this kind of a thing.
Yeah, I have some resources. First of all, I can offer you a goals of care conversation. I don't charge for that. So I can help you and your family have that. I have a booklet. It's called Hard Choices for Loving People, that I can provide you. And it goes over a lot of the different types of choices and what you need to think about with those choices. I have a dementia specific directive that I mentioned that I can give to you as well. So it's kind of, we're piecing it together. You know, every time I find a new resource, I have a large, you know, in my documents in my computer, I have so many different types of advanced, you know, so I'm always looking for what else what's better, you know, what's a better option to help people. Like I said, I'm not clinical. Teresa actually on this call, Teresa's a dementia expert, and she'll be coming up in a upcoming talk. So maybe Teresa and I can work together on developing some really great tool. Nurse. So I'm not clinical, but yeah. So good questions. I wish I had better information, and I don't know if the Alzheimer's Association has a specific list. You guys, Dana, do you know?
Not that I'm aware of.
So it sounds like something we need to put our heads together and create. But in the meantime, I'm happy to be a resource for you to have the conversation and to give you some resources that I have as well.
Thank you.
At the end of this, you'll have my contact, okay?
Great. Thank you, Lynda.
Thank you. Anybody else before I move to the next? Okay, great questions, you guys. Thank you. All right, so here's more about hospice. So the terminally ill patient, what matters to them? Well, they want their pain and symptoms to be controlled. That's one of the most important things that we can help them with, because that greatly affects quality of life. They want to achieve a sense of self-control. And this is where I think that our healthcare system often fails people is, you know, kind of taking away decision-making agency. I think it's really important. And I think that as newer generations are doing more of this, asking questions, pushing back, advocating, being a participant in healthcare decisions, not just letting the doctors tell you this is what you're going to do next, you know. So I think that one of the great things that we do in hospice is we really engage the patient and family in the care and really listen to them and their needs and give them again, the word self-determination, self-control. We want to help them find meaning in life because, you know, as your life is coming to a close, you tend to look back and look at, you know, the lifespan and did my life have meaning? What can I do with the time I have left? Meaningful time. How do I want to spend that time? So we really work with people on what is important to you with the days of life that you have. You want to live fully and comfortably as much as possible with the days of life that you have left. We really, you know, the patient really often worries about the care burdens on their family and their loved ones. They worry about how hard it is to take care of them. They worry about what their family's going to go through once they pass. And they just don't want, you know, people will try to protect their loved ones. And they worry, a lot of them worry very much about the burdens that they are placing. So us coming in as support to their loved ones is helping them to feel less burdened as well. One of the things that this one is really important, terminal illness acknowledgement, discussing end of life wishes. This is something that sometimes family members have a hard time doing with each other. The parents want to protect the kids. The kids want to protect the parents. Nobody wants to acknowledge what's happening because it's hard and painful. But if you're facing the end of your life, you are aware of that. And that's a profound experience, and you really need to talk about it. And you need to have someone that you can share that with, who you don't have to worry about, you know, and that they're going to be able to hear you and not fall apart or whatever. So having, this unbiased outside team come in and help you to talk about your wishes and acknowledge the fact that you're at the end of life and what matters to you can be really confirming. It's important for patients to trust their doctor, respect their doctor, and feel also respected and seen as a whole person by their doctor. And hospice physicians are unique. Many doctors, as you're facing chronic illness, they're trained on an organ. They're really an expert on the heart, or they're an expert on the kidneys, or they're an expert on the lungs. But, the hospice physician is trained to look at the person, the holistic system, the family, the whole, and it's a whole different kind of partnership relationship. I think that, that there's a different experience. So not that other doctors, I'm not saying that other doctors aren't respected or trusted or don't treat their patients that way, but this is just a unique type of specialization that I'm referring to with hospice. So when we talk about treating pain, pain is not just, when you're at the end of life, it's not just a result of physical symptoms that are causing pain. There's a multitude of physical problems that do cause pain. In addition, there's a lot of emotional issues at the end. You may be dealing with anxiety about the fact of what's going to happen next. You may feel anger. A lot of patients at the end of life feel angry about, they may feel robbed, that this is happening too soon. They may, it's part of the grieving process to feel these feelings. And depression is a very big part of emotions at the end of life. And these things can increase pain as well. And these are things that we can help people work through. Interpersonal problems, financial stress, and family tension, and loneliness. These things all also contribute to pain. And these are things that our social workers can work with patients and families to ameliorate. And then when we don't accept that death is coming, whether that's the patient and or the family, that makes everything a lot more painful and a lot harder. So when we come to a place of acceptance, where we understand that we are where we are and this is the reality and we're not going to change it, then we can have a sense of peace and just instead of fighting it, start looking at what can we do to maximize quality of life instead of fighting the fact that something we can't change. But these are all components of pain, and this is how we look at pain and symptoms from a hospice perspective. Caregivers, it's important to them that their loved ones' wishes are honored, and so we're always working to make sure we understand their loved ones' wishes, that we include everybody in the decision processes. It's helpful to them to have support and assistance at home, instead of having to run to doctor's appointments and hospital appointments or hospitals, pharmacies. That's one of the things that's so nice is care comes to you. You get practical help and honest information, and you have someone helping you with that care. We're not taking over the care. The caregiver is still providing the care. We are an additional layer of support, but we are available 24/7. We have a nurse by phone every day of the year, 24/7. So if there's anything that happens in the middle of the night, you don't have to call the squad and go to the hospital. You just call the nurse line, and if we need to send someone out, we can. We're great listeners. We'll respect your privacy, and we'll remember you and contact you after the death of your loved one to make sure you're doing okay and you're breathing. It's not complicated or stuck. And so this is looking at the quality of life, psychological welfare. So we're looking at the place of death and how comfortable physically, psychologically, how was the quality of life experience for the patient. And so this kind of mauve, the second bar is at home with hospice. And you can see the highest psychological welfare and highest quality of life is at home with hospice. With the physical comfort, it's the second highest. The the highest would be inpatient hospice. And that's because, you know, if we need to provide nursing, more skilled nursing care and higher, more complex intervention, we're able to do that better in an inpatient setting. So for patients who have the most pain or symptom burden, then sometimes we end up having to go to the unit because we can make them physically more comfortable. But our goal is always to keep them at home with hospice if possible. And then you can see, of course, the hospital setting and then the ICU. So if you look at physical comfort, the ICU is the most uncomfortable way to die. Because if you're in the ICU, they're going to do everything possible to stop you from dying if they can. And if you're dying anyway, then all of that care is futile and aggressive, and it causes pain and suffering. And it's harder for the family members as well when their loved one has that type of end of life experience. If you know that your loved one was comfortable and peaceful and surrounded by love and caring and in a comfortable environment, it makes it much easier for you to breathe without complications as much, you know. So in terms of hospice patients, dementia is up there right under, you know, cancer being the primary reason for patients to our part of our admissions is, you know, highest is cancer, dementia is number 2. And I think over time that dementia keeps climbing that list, and probably will keep climbing that list. Says here, Medicare pays for 1/3 of the cost of treating cancer in the final year. 78% of that spending occurs in the last month. That's something that we find, you know, as people are getting closer and closer to the last month of life, the cost of care is increased, and that's because, you know, of increasing interventions, increasing more and more aggressive interventions in an ICU setting, especially. Again, a lot of that being futile and causing more pain and suffering and more burden than actually is doing any good. All right, so now before I go to who qualifies, I want to check in again for questions.
If you have any questions, you can unmute yourself. I don't see anything in the chat.
Yeah, Lynda, this is Larry Dollar. Just a question about dementia. It kind of goes back to a good friend of mine. His wife passed last year, but she was in a nursing home for almost 12 years, I guess it was. And she had started, I guess, dementia in her early 60s. But he didn't realize that she had a problem at all. And it really, after he finally understood that what was going on, he had major guilt feelings about it. His daughter had moved from Dayton to California, and she came back about a year later and said, "Hey, Dad, what's going on with Mom?" And he said, "What do you mean?" He didn't understand. He really had no idea. He said, she just seems to not remember things. She has lapses of memory, all these sorts of things. And he didn't realize it at all. He just was not picking up on it. So early stages, how do you, even address that, and trying to get the person that has dementia that's going into that to even go to a doctor or go to somebody to get some sort of guidance. It seems like a kind of a murky water kind of a thing in the beginning. As the time went on, she got to a place where, just a few years into it, she didn't recognize him, didn't recognize the daughter, anybody. And she was just kind of there. And he would go see her every day at the nursing home and sit with her, and she'd have no idea who he was.
Yeah. So I'm not sure if I am clear on your question for me. And I'm not sure if I'm the person to answer your question either.
Sure.
Yeah, Larry, this is Dana Ritchie with the Alzheimer's Association. I would recommend another program that we offer called the 10 Warning Signs. And that talks about what is the difference between normal aging? Because we all get a little more forgetful and slow down and,
Sure.
tend to kind of not like change, things of those nature as we get older, but there are some specific signs that are beyond just normal aging, because dementia isn't normal aging. Everyone doesn't get dementia. So it talks about what's the difference, and it also talks about how to get your thoughts together to talk to somebody, to get them to go to the doctor, because you don't want to say, hey, I just took this great program from the Alzheimer's Association. I'm really concerned you have Alzheimer's. I think we need to go to the doctor. Nobody's
Yeah,
going to
right.
want to go to the doctor to be told that they
Sure.
have Alzheimer's. So we get into, how do you think about having that conversation, and what do you need to talk about in order to get a loved one to a doctor to have a diagnosis? Because sometimes we have irreversible signs and symptoms that present themselves like some type of dementia, but we could have a vitamin deficiency or a very extreme thyroid issue, or lots of things that are actually reversible to some degree. So it doesn't mean that you're going to have a dementia, but I would definitely recommend the 10 warning signs as a follow-up program to this. When we send out all this follow-up information tomorrow, you'll get a schedule of all the Alzheimer's Association programs we have for the rest of the month, and that'll be one of them.
Good deal. Okay, thank you very much. Okay.
Yeah, thanks, Larry.
I'm glad you were on here, Dana.
Yeah, no problem.
Okay. Anybody else before
I have a question. Is that having lost my father last June, the good news was during COVID is that because he was in hospice, we were allowed to visit. And I'm sure that this is something that varies again by state and by facility, but it was very important to us that to understand what the variables were if he was in one setting versus another setting in terms of who could visit. And I'm sure that is something that has morphed as the year has gone on. The other thing I was going to suggest is that one of the things that, excuse me. One of the things that was most comforting to my father is that we fortunately had access to technology where we could FaceTime my dad, and it allowed basically all the grandchildren, all the family members to talk to dad before he died. And that was a very comforting situation. And I guess my other question would be is who determines their hospice options? How does somebody become savvy enough to know what hospice to go with?
Oh, okay. Well, that's a good question. So when you needed hospice for your dad, was he at home initially or was he in a facility?
He had been in a nursing care facility. He had a crisis and was transported to the hospital. And then when he was discharged from the hospital, it was a matter of what hospice do we take him to? And of course,
gave you a list of choices.
The hospital gave us a great list of choices. The problem is that he had probably the last happiest 2 years of his life living in the independent living situation that he was in. And we knew that he would be most comfortable being around his friends, but probably had the least comprehensive hospice care, where again, and I understand this was during COVID and there were limited hospital beds, there was limited multiple supports.
So yeah, and your story is very familiar, very common, where something happens and all of a sudden the person is in the hospital, and now all of a sudden we're talking about hospice, and it's as if this just happened to all unravel suddenly. But truthfully, somebody could have seen that up the road further, somebody at the facility, somebody. So part of my my goal is to help patients and families, or or facility staff identify much earlier somebody who's going to end up needing hospice in the next 6 months or to a year, because often there are lots of signs that we miss, and then all of a sudden it's a crisis. And then you have to make a decision and you have to, figure it out quickly. And that's never good to be in a position of making tough choices without time to look into information. That's kind of speaks to your problem
norm.
of decision, and now we don't have all the information we need to make a good decision. We don't have the time to get the information to make a good decision, right? In terms of which hospice to go with too, a lot of times what we see is the hospital may have one that they particularly like to recommend. So they'll give you a list and they may kind of steer you in one way. Or a nursing facility will do the same thing. So it's important for people to know that hospice is a choice, and that if a facility is telling you this is the hospice we use, you have the option to interview more than one and choose the one you feel more comfortable with. You can ask your, friends, who have you used, who are you happy with, and you can, but those things take time, and that's why it's really good to be proactive, so that you have the time to look into these questions. Right?
Mhm.
Yeah. Good questions. Anybody else before I move on? All right, well, thank you. Okay, so qualifying for hospice. So these are Medicare guidelines, or not guidelines, conditions. Life expectancy is supposed to be 6 months or less if the illness runs its normal and expected course. Now, that's really hard for anybody to know. And doctors are notoriously not good at, they often overestimate life expectancy. But you need an attending physician and a hospice medical director to both certify that they believe this patient's life expectancy is 6 months or less if the illness runs its normal and expected course. So that's the first criteria. It doesn't mean that they absolutely are going to only live 6 months or less, though. It's just the initial question that two physicians have to agree to. Once they are qualified for service, they have 2 90-day election periods. So that means 90 days, reevaluate. Still eligible? Yes. 90 days, reevaluate. Still eligible? Yes. Then every 60 days. So they're constantly being evaluated. Do they still meet the qualifications for hospice? As soon as they stabilize and are no longer meeting qualifications, hospice is required to discharge them by Medicare standards, okay? So the attending physician, if there is one, and the medical director from hospice both certify in writing at the beginning of the first 90-day period that that patient is terminally ill and meets those qualifications. Going forward, they're constantly being reevaluated. In the subsequent election periods, it's not both physicians who have to keep certifying, it's the hospice physician, because the hospice physician has that expertise. And then prior to the beginning of the third benefit period, so the first one is 90 days, the second one is 90 days. And once you start getting into the 60-day periods, and prior to each subsequent benefit period, then the hospice physician has to have a face-to-face encounter with the individual. And now you can have a nurse practitioner who works for a physician to do that as well, to verify that this patient is continuing to be eligible for these services. In terms of length of stay in a hospice program, this is kind of old data, but at this point, the majority of people were in hospice less than 7 days. And that's because, again, when they're waiting too long to take advantage of the service. So you have eligibility for 6 months or, well, if you keep getting recertified, the longest period that I've heard of, I think, is 9 years of hospice care, which is really a high number. But with dementia, especially because the disease is progressing slowly in some cases, we have patients who are on service for years if they start early enough. So waiting until the last week of life is unfortunate because you had access to really great care and services that you didn't take advantage of because you waited. So you can see that now with dementia, it's more like 4 months is the average. But there are that's the average, but there are cases where dementia patient is on for, like I said, for years because they qualified and then they're progressing in their illness, but at a slower rate.
Cynthia, did you have a question?
Well, I did, but I'm also having problems hearing. The audio is breaking up. Is it breaking up for anyone else, or is this my?
I heard it breaking up too. I had a hard time hearing those last few sentences you said, Lynda. Was she answering your question, Cynthia?
Well, she was addressing. I was curious about dementia because it will be terminal if the person doesn't fall down or to do some, have some accident or something like that. But the duration of the term, is so unclear. How do you figure that out? How do you
Exactly. You bring up a good point, Cynthia. And see, initially when hospice began, it was mainly cancer that we were caring for, which was a lot easier to predict. Not that that still isn't really poorly predicted. It also is, but dementia, you're right. It's very individual. It progresses at such a varied pace with different individuals and depending on comorbidities. So you're right. It's really hard to predict. And like I said, doctors are notorious for getting that wrong. So it's kind of a general guideline that two doctors would say, sure, that could be, it's not unrealistic that this patient could be within their last 6 months of life, but often they're wrong. It's just kind of Medicare's guidelines are, the doctors have to feel comfortable saying that. There's additional guidelines in addition to that. These are just general criteria, but then for each disease, there are specific guidelines that they look at. And then they said, it's just that certification period is the 90 days, but then there's the next period of 90, and there's unlimited 60-day period. So I'm not sure if you heard me, but oftentimes dementia patients are on our service for years, and sometimes many years, up to, I've heard 7 in one case, 9 years in another case. Now that's not the norm, but that is the average. So I looked into earlier today, what is the average for dementia patients? It was more like 4 months, but that includes those patients who have many years of service, and then averaged in with those patients who waited until very late service.
So is that something you would be able to weigh if you were doing the counseling or the care, the goals of?
So we would have, in the goals of care conversation, I am not clinical, so I will not say yes or no, this person is qualified. The goals of care conversation is to help the patient and family clarify and communicate their wishes, their values, their goals. If their goal includes hospice, if they say, I would like to know if I'm qualified, then I get a nurse involved, and the nurse determines along with the physician. So the nurse will do an assessment and then go back to the physician and find out if the patient is qualified.
Okay, thank you.
And then, one thing I was telling a family earlier, it's okay to have multiple assessments. Sometimes with certain illnesses, you can have a good day and maybe the assessment was on a really good day and they didn't exhibit, they didn't seem to be qualified, but that a different day, it might have looked differently. So, or, a little bit further down the road. So I have had experience with somebody not qualifying, but then they check again a little bit later and don't qualify, and they check again, and then they finally do qualify. So it doesn't cost anything to have an assessment. And if things change, you can ask them to come back and assess again.
Okay.
My goal is always start as soon as you possibly can, as soon as you make qualifications. And then if you get discharged because you're doing too well, that's fine. And if things change and you're not doing well, you come back. You know, sometimes patients will come off and on. They'll come on for a period of time and then they'll discharge and then they'll come back for a period of time. Stephanie, go ahead.
Well, I'm just going to say, I think that's an element that shows that a hospice could truly be cost effective in terms of the overall medical bill. And I think that my mom was being treated at a teaching hospital, and the number of scans and MRIs, et cetera, that she had, my grandchildren will be paying for those. But,
Right.
and
Yeah.
I don't mean to be facetious, but I just think that in our culture, if we looked at hospice as being cost effective and realistic about what was available and how we can support people, it would be much more accepted and it would benefit everyone better.
Right. And that's what I always feel really bad about when people wait until the last 7 days of life to call hospice. I just think, oh my gosh, not only the money, but also the support, so much that you did not take advantage of, that you had access to, that you were
Right.
trying to do everything on your own and struggling when you had so much support available, you know. Yeah. So that's why I'm always trying to help people see hospice differently and not be so afraid of calling. You know, for me, with my loved ones, I'm going to have them assessed as soon as I think it's possible that they may be eligible. And if they don't make the qualifications, I'm going to wait a little while until I see a few more changes and then do it again. And then if I still don't have them meet qualifications, I'm going to wait a little while and then do it again until I get them in at the earliest possible, you know, as soon as they possibly qualify, they're on service and they have that. Because that's the way to have the highest quality of life for both the patient and the caregiver. So it's really important that we don't have this negative stigma where we avoid hospice and end up, you know, cheating ourselves, really.
Mm-hmm.
Thank you for the comments. So number one criteria is, what are the patient's personal goals? You know, I think hospice is great and everybody should want it, but that's my value system. Somebody else may say, I want every possible intervention until the last week of life. And that does happen. We have people who wait until the last week of life and they still want to know, is there anything more I can try? You know, so patients' personal goals are really important. And that's where we do the goals of care conversation. What else is important to look at? What is the burden of treatment and what is the potential benefit of treatment? That's really something that isn't well done in society today. It's almost like, if there's a treatment, try it. Instead of, well, what is the treatment going to cost me and what potential benefit is there? Sometimes the potential benefit is so small and is so outweighed by the burdens. Sometimes the burdens of treatment cause end of life sooner than the disease. Sometimes hospice patients live longer than treated patients because of the side effects of treatment. So it's important to really look at this kind of analysis instead of just taking the next thing and the next thing and the next thing that's offered. Does somebody have a question before I hear noise? Do I need to stop for a question or no? Okay. Changes in functional status. So we look at the activities of daily living and what are people able to do independently versus what do they need help with? Dressing, bathing, feeding themselves, mobility. I should have written these down because I always, whenever I go through this, I'm always like, wait a minute, I'm forgetting something. But the self-care, you know, are they able to get up out of a chair or out of a bed? Do they need help with transfers? Are they able to move around or do they need help? Are they going to fall, for example? Do they need a walker? Are they able to prepare meals or feed themselves? Just all the activities of daily living. The more dependence there is, if you have 3 out of 6 of those that you're dependent on help, then that's a functional status that's significantly impaired to need assistance. The PPS is the Palliative Performance Scale. It's a tool that is used. There's other tools. There's a FAST scale as well. There's different tools that clinicians look at to evaluate whether somebody qualifies for services. So it looks at, on the Palliative Performance Scale, ambulation, the ability to move about versus being bedbound, activity and evidence of disease. So that would be the activities of daily living that we were just discussing. Self-care, well, that's self-care as well. So evidence of disease, there's lots of different, depending on the disease, there's lots of different factors that we can look at. Again, self-care, whether they're fully able to care for themselves, how much assistance they need to all the way up until total care. Intake of food, so normal in the beginning and over time it's reduced. You may see changes in the ability to swallow, choking, pocketing food, things like that, loss of appetite, leading to extreme, unintentional weight loss, muscle wasting. You'll see that that's noted there. And then also on the Palliative Performance Scale is conscious level. So full to confused to drowsy and confused to all the way up to coma. So they're looking at all of these factors when they're deciding if someone is eligible. And as the disease progresses, you'll see more and more hospitalizations. So when you start to see somebody who's in and out of the hospital frequently, that's a pattern that you should be paying attention to. More emergency department visits, increased utilization of healthcare services, more and more doctor visits. And then again, the disease progression depending on the disease. These are all the general criteria. So for neurologic conditions like dementia, we also look at what are some relevant secondary or comorbid conditions associated with impairments. So, oftentimes we're not looking at just one organ, being the brain, that's failing. There's multiple systemic organ failure. The kidneys may be compromised. The heart and the lungs are also compromised. So the more compromised health status, that all plays into the picture of whether someone qualifies for our help. Let's see. Okay. So this is talking about the FAST stage 7. So Palliative Performance Scale goes from 100% down to 0 on levels of palliative performance. The FAST scale has 7 stages. So now this says for end stage dementia, FAST stage 7, inability to ambulate without assistance, and assistance could mean a walker even, and inability to speak or communicate meaningfully. And so that's kind of subjective. And also I have seen with dementia, everyone manifests differently. So there are some patients who don't lose the ability to speak, even in late stage. So I think that there are general criteria, and again, I'm not a nurse, it's the nurse who determines, but they're looking at the whole picture. Some comorbid conditions that we see as it advances, aspiration pneumonia, because they're having a difficult time with swallowing, sepsis and decubitus ulcers. That's, your immune system is compromised and your healing is compromised. Again, we talked about altered nutritional status, losing weight, muscle wasting, maybe sleeping so much of the time that you're not eating as well. And that also contributes to the ulcers because you're in bed so much or in a chair so much that there's pressure ulcers, and then your skin quality is deteriorating as well. And then just having fevers, even with antibiotics, the fevers are continuing. So I don't have all 7 stages. I just have the latter stages for you to look at here. But you can see, how this kind of progresses. And again, for me, I think that it varies a lot with patients. I've seen a lot of different dementia patients who are qualified for hospice, and they look all different. So my thing is, if you are at all curious or you think that your loved one could qualify, it does not cost you anything to have an evaluation. And if that nurse comes and says, nope, not yet, then I would say, what are you looking for that you're not seeing? So that if I notice it, I can call you to come back. Okay. Again, with more kind of the stages, the things that you might see as later stage. And so you're going to have these slides, so I won't go over every line with you. So for end stage Alzheimer's disease, cognitive disorders consistent with FAST stage 7, the inability to ambulate without assistance, the inability to communicate meaningfully with speech limited to approximately a half a dozen or fewer intelligible or different words, loss of activities of daily living, the functions of bathing and dressing, for example, and having incontinence of bowel and bladder. And then in addition to comorbid, also adds other disease states adding into that picture. Here it says patients referred for other terminal diagnoses, for example, cancer or COPD, also can have mild or moderate dementia. And that's, these systems work together. If you have a compromised blood flow, compromised oxygen due to COPD, CHF, these things also compromise, the blood and oxygen to the brain. So these things happen, they coexist. So in conclusion, it's important that you have advanced directives. 18 and up, everybody, no matter how healthy you are, everybody needs advanced directives. Advanced directives increase the chance of patients receiving the kind of care they wish, only if, though, they also communicate those wishes in a comprehensive way to their loved ones. And that's where the goals of care conversation is really important. So the goal of hospice is to address the factors that are important to terminally ill patients and their caregivers, to manage pain, assist with end-of-life aspects, and support caregivers up to and including the death and afterwards. Depending on the patient's needs, hospice offers 4 levels of care: routine care in the home, intensive comfort care in the home, inpatient care, and respite care, which we've gone over. Studies find both patients and caregivers report higher levels of quality of life and comfort when the place of death is either hospice or home versus hospital or ICU. Qualifying patients are granted some financial relief as well because hospice care is fully or partially covered by Medicare. And VITAS can provide assistance with goals of care conversations and determination of eligibility for hospice, and there is no cost. And then you have my information there. Now, I am going to quickly, let's see, how are we doing on time?
We're about 45 minutes over our hour. So we've been together an hour and 45 minutes, but we have time for questions always if people have questions.
I am so sorry. I didn't even look at the time.
That's all right. We had a lot of great dialogue.
I was going to try to quickly find that slide about if you don't have an advanced, a power of attorney, but I'll send that to you for everybody.
Yeah, send that and I'll send it out. I know the person who asked that question had to go. Anybody have any other questions though?
Just wanted to state that I actually joined the conference because I have a dear friend, a friendship of 40 years, that she is 67 and she's had early onset Alzheimer's. And to be so closely involved with somebody and watch the progression of the disease and wanting to know appropriate support, this has kind of jumped up quite a bit ahead of where we needed where I needed to be in terms of information, but it's very valid information. But it was also very cathartic for me in terms of understanding and appreciating how my family and I dealt with the loss of both my parents. So I wanted to thank you because it really was well organized, and Lynda's communication skills are amazing.
Oh, thank you, Stephanie. I appreciate you so much. For your friend, I'll have to see if you'll email me what you're actually looking for. I'll try to get you some resources.
Okay, thank you. Yeah, I mean, her husband is very proactive. It's just like, I feel like I'm supporting two people, and I want to be appropriate and also just understand where we are on a particular day.
Yeah.
Sure.
And don't
Well,
forget about the Alzheimer's Association resources. So we're obviously the experts on the dementia part of it. We can help you understand what to expect with each stage. We can provide support groups that you could attend to help you, talk with other people who've been through this to understand what might be appropriate or what might not be. So I'll provide information on all of that in our follow-up email too.
That would be terrific. Thank you so much. This was very valuable.
Thanks, Stephanie. I think Michelle has a question.
Yes, it's on the final topic of advanced directives.
Uh-huh.
My mom is no longer capable of reasonable thought regarding advanced directives, and she just started crying the last time we even brought it up.
Okay.
So I can't sign the form for her because she's still somewhat cognizant.
Yeah.
How do we approach that? Because we have no advanced directive now because she won't agree to anything. She won't even think about it.
Right. Well, I'll get you that delineation of who's in charge when there is no power of attorney. And then unfortunately, what happens is the family ends up put in the position to make the decisions for the patient. So the best thing that you can do is really ask good questions to understand what decisions you might be facing, and do your research to know what decisions you would choose for her. And just, knowing just kind of piecing together what when you think back over experiences that you've had or conversations that you've had over your lifetime with other loved ones who passed away. But yeah, it's going to be the family, and that's why we really encourage people to have advanced care planning, because it is such a burden to place on your family to have to make these tough decisions without your input. So unfortunately, you'll end up making them for her. If you're in Cincinnati or Dayton, I'm happy to help try to talk with her, just to try to get her to communicate her wishes. But I understand that it's challenging. It might be more challenging for family to do with her than me. But that's just an offer. But otherwise, you're just going to be facing the decisions yourself as a family.
We're in Kentucky. Do you have a similar group in Kentucky?
How far from Cincinnati are you?
Right across the border, Edgewood.
I'll come to Kentucky. We don't serve Kentucky in terms of hospice, but I'll come and help you talk if that's something you would like to do. Or we could do it, well, I wouldn't do this with your mom. You and I could do it by Zoom, but, or by phone. But with your mom, it would need to be in person. The goals of care are not effective, as much, especially with somebody who has cognitive impairment. You need to be in person. And if it's not too far into Kentucky, I don't mind doing that if you'd like.
All right, thank you.
You're welcome.
And then the last thing I would add is regarding advanced directives, some of the questions we had that Lynda answered very well. If you have legal specific questions though, sometimes we move more to where we need more of a lawyer's point of view on some things. So when I sent you all the reminder earlier today with the link for this evening, I did mention to you that tomorrow at lunchtime, we actually have an elder law attorney that will be giving a program on legal planning throughout all stages of dementia. But it's a very good program to take, even for people who don't have dementia currently. It's just a really good reminder of how things work and how effective is a will versus, other things that we set up for ourselves. When does that will take effect after you pass compared to other things that you have decided or documented? And then she definitely gets into the difference between a healthcare power of attorney and the financial power of attorney, durable versus not, all of those things too. So that's another thing to check out from, like I said, just a lawyer's point of view.
Great. I'll try to make that too, so I can.
Yeah, please register. Are there any other questions? Jill, did you have a question?
Well, actually, you were bringing a new one up, Dana. I'm registered for tomorrow's event, and actually, my dad is going to be watching it with me because they don't have any of the necessary legal documents signed up. Will they be covering some of the Alzheimer's specific things that were kind of brought up earlier on in this, and not just the basics that everybody needs?
She can, yes.
Okay.
You may have to ask her some questions, but I've sat in this program 3 times, the one we're having tomorrow, and I'll be the facilitator on that one too.
Okay.
So she definitely can get into that. She has answered those questions before, so feel free to ask
Perfect.
those, definitely.
Thank you.
Sure, thank you, Jill. Ray, did you have a question or a comment?
Yes, I have one quick question on the respite. If you want, let's say, a 1-week respite, I think, is that the max, I guess?
I believe it's 5 days, but don't quote me on that. It might, I read that it was 5 days, but I feel from my memory that I thought that I saw it longer than that, but that's what I read, that it was 5 days.
So is your person that you're taking care of, is it done in the house, or do they get moved to somewhere else?
Yeah, to the inpatient unit.
At a inpatient at a nursing home, or what?
Well, generally they like to bring the person to our hospice facility if that's feasible. But in some cases, they may have to do a contract bed in a nursing home if they're not able to, if the distance is a factor.
Okay. All right. Thank you.
You're welcome. I do apologize to everybody for keeping you late. When I get talking and about this stuff, I don't even think about time. I'm sorry about that.
No, I understand. Oh, yes. So Laura's mentioning something I meant to mention myself, and I'm glad that you said this in the chat. She said she found the Advanced Directive for Dementia website by Dr. Gaster. That she thought you mentioned early, and she was looking at it, kind of multitasking, and said it was very helpful. But she's also mentioning, which popped to my mind earlier too, a website called the Conversation Project. Are you familiar with that, Lynda?
I sure am. Yep.
Can you talk a little bit about that?
Well, when I first started this position, I looked into the Conversation Project. I haven't looked at it lately, but basically there are many resources. The American Bar Association has amazing resources too online, but there are many initiatives that are geared to getting people talking and planning, and that's what I'm trying to do here as well. Now, I can't speak a lot about the Conversation Project because, like I said, initially I did look at that, but then I ended up gravitating toward a different one, which is, so there's a man named Michael Hebb, and he created a program called Death Over Dinner. And I facilitate the Death Over Dinner experience. I was telling Dana I would be happy to do that on an ongoing basis for anybody who's interested. But it's really geared toward helping people talk about death and dying, the fact that we're mortal, getting planning done, talk about our values and our wishes. And it's done in a way that's very enjoyable. People really, I know that sounds weird to say, but people really do give the feedback that this is an experience that's very bonding and very intimate and very helps them really to have this experience. So, but honestly, I could overwhelm you with so many different resources. the database that I have amassed over the years. I have all the conversation project stuff. I have the, Barack Gaster, the dementia advanced directive I learned about through Michael Hebb. But there's a whole movement of people. It's called a death positive movement. You've probably heard of the positive aging movement, maybe. But there are people who are like, let's look at aging in a positive light. Let's look at dying and the fact that we're mortal. Let's not make it such a taboo, sad topic. Let's look at it like, in a more positive light. So there's a lot of people who are embracing the fact that we age and the fact that we die as normal parts of life. And let's not hide those things in the shadows, because we can live more fully and die more beautifully when we don't avoid those realities. So yeah, I have a whole lot of resources I can send you guys if you're interested. I feel like I overwhelm people because I have too many. There's some really, though, American Bar Association, amazing, really great tools. Like I'll send you some, Dana, you decide how much you want to share.
No problem. Any last questions before we sign off for tonight?
Thank you so much for the program. It was wonderful.
Thank you for hanging in here, and thank you for asking great questions and all your contributions as well.
Yeah, thank you very much. It was very informative.
I can tell you guys, I was saying, I have individual presentations of each part of that I picked from. So if any of that you wanted more in-depth, I could do in-depth advanced care planning, in-depth goals of care, in-depth hospice benefit. But I just wanted to give you a taste of each thing because I think they're all important.
Reen, did you have a question?
No, but I just wanted to say thank you very much. It was informative, so very good.
Thank you, I appreciate that.
Yeah, thank you, Lynda. It was such great. I mean, there's no reason for us to cut off great content. So that's why I didn't say anything about the time until you asked. I appreciate you answering everyone's questions, and thanks everyone for showing up this evening. Hope you guys have a great rest of the week.
Don't hesitate
so
to
much.
ask me if I can help you guys. Thank you so much for the opportunity, Dana.
Absolutely.
Thank you.
Thank you.
Good night.
Bye.
Bye.
Bye.